Chapter 2. The Clinics. Becoming an Old-Time Doctor. La santé pigou riche. Health is the greatest of riches. Haitian proverb. As a medical student, I spent time with the general practitioner who delivered me. Dr. Donald Sharbaugh was a dying breed. In his 40 years of practice, he had done everything: neonatology, orthopedic surgery, gynecology, along with the usual care of sore throats, strained backs, and high blood pressure. As is typical of his vintage, he had little use for modern medicine and referred to it as CYA, cover your ass medicine. He resented the intrusion of government, lawyers, and high technology into his domain. However, he realized his era was passing and perhaps felt it was a good thing, although he never admitted it. Dr. Sharbaugh told me that medicine is nothing but a battle of wits between you and the patient. Observation is key. You must begin examining the patient as soon as you lay eyes on him: his gait as he walks into the room, how he shakes your hand, his facial expressions as he describes his problem. To him, medicine is an art, not a science. Although many would agree with Dr. Sharbaugh's philosophy, few actually practice it. Spurred by the public's demand for technology, legal considerations, and a seemingly infinite supply of money, American physicians are forced to practice high-tech defensive medicine where objective data are revered and instinct and judgment are secondary. If the patient has a headache, get a CAT scan. If he has chest pain, do a cardiac catheterization. Dr. Sharbaugh's generation laments this trend, but nonetheless, it is the wave of the future. It is leading to a cold, dehumanizing brand of medicine, but more correct diagnoses are made earlier so that rapid treatment can be initiated. Frequently, though, technological facts and all the tests are negative. It is then concluded that the symptoms are psychosomatic, a diplomatic way of suggesting the patient may be crazy. This is preferable to admitting that medicine is still in a state of abysmal ignorance, immobilized by the immune system, baffled by the brain, and confounded by the common cold. Medicine is still an art, not a science. In Haiti, medicine is truly an art. It was just me with my stethoscope and the patient, both sitting on hard wooden chairs. My decisions were based on observation, instinct, and a few simple lab tests. If I thought treatment was warranted, I gave it. Those who were dying, I just tried to comfort. If I was unsure, I still had to make a decision. There was no one else to ask. There were no bureaucrats harassing me with meaningless paperwork. There was no malpractice to worry about. It was real medicine in its primitive form. Dr. Sharbaugh would have loved it. At first, when I began working in the clinics, I felt woefully inadequate. In front of me were dozens of Haitians speaking a language I could not speak, from a culture I did not understand, and with diseases I had never seen. I learned quickly I had no choice. The tropical diseases that had been textbook abstractions were now three-dimensional reality. Soon I was able to treat the common problems: tuberculosis, malaria, typhoid, and others. Slowly but surely, the rapid blur of guttural syllables emanating from their mouths began to make sense. Within several months, I was conversant in Creole. Also, I had to learn physical diagnoses, or proper examination of the patient. In medical school, careful examination of the patient is stressed. In reality, it never happens. It had been replaced by CAT scans, ultrasounds, and nuclear imaging. Since these were not available to me, my physical diagnosis book became my Bible. I had to listen carefully to the lungs, inching my stethoscope across the front and back of the chest, trying to hear a wheeze that would add to my suspicion of tuberculosis. When I examined the abdomen, my fingers probed under the ribs and pelvic bones, searching for an enlarged organ. While doing this, I watched the patient's face for the slightest grimace that signaled tenderness or discomfort. Having acquired these new skills and knowledge, I still faced another problem. Haitians frequently lie about their symptoms. This changed the rules completely. I could no longer rely on the cornerstone of medicine, the patient's history. It is the history, what the patient tells you, is the problem, where 80% of the diagnoses are made. Physical exam and lab tests are only confirmatory. In the United States, other than in workers' compensation cases, physicians hear the truth as it is perceived by the patient. If a man complains of chest pain, it exists. He may exaggerate it, perhaps, tailoring his symptoms to the latest Reader's Digest article, but he wants to receive the best possible care and therefore gives an accurate assessment of his problem. In Haiti, it's different. Port-au-Prince is replete with social welfare organizations dispensing free food and medicine. In a country with massive unemployment, many make their livelihood shopping place to place with the same story. If they can obtain a surplus of medicine or food, they can sell it. And you can't blame them, they're just trying to survive. It was truly a battle of wits between me and the patient. Often a patient would complain of abdominal pain. I would ask the usual array of questions. Do you have fevers, diarrhea, or painful urination? They would respond yes to every one. When I examined them, I found nothing wrong and told them so. Then the truth would come out. They would ask me for food, often telling me they were good Catholics. This only strengthened my resolve not to give anything. I would reply, "M'docte, Papa Noel, I'm a doctor, not Santa Claus." I had to balance compassion with firmness so the neediest got help. It was especially disheartening when patients would use their sick children to get charity. It was even possible to rent pathetic, starving children, either to take to the clinics or to use for begging on the streets. One woman brought me her 13-year-old daughter. The child was wearing a tattered, sleeveless, drab red dress and weighed 55 pounds. She had a cough and fever, and this, combined with her listless, emaciated appearance, made me quickly conclude she had tuberculosis. I gave the mother the medicine for her and told them to return weekly to renew it. After finishing work for the morning, I went to have lunch with a friend who worked for the Salvation Army. During our conversation, I described the plight of this family. Barbara, a handsome Swiss woman of 35, had a quick flash of anger in her eyes. She had seen them today, too. The mother had been bringing the daughter to the Salvation Army for the past year. Barbara suspected that the mother was selling the medicine rather than giving it to the daughter. She had 12 other children and no husband. When this child dies, the mother will shop with one of her other children. The vast majority of patients I saw needed help and needed it desperately. Illiterate, broke, and without marketable skills, they had no hope of advancement. They needed to eat, to sleep, and had no way of obtaining money to do so. They were sentenced to a living hell where their very existence depended upon the charity of others. Healthcare is available from the Hôpital Général located in central Port-au-Prince. Although a consultation is free, everything else must be paid for, including linens, food, medicine, syringes, and lab tests. If surgery is needed, the patients even have to purchase the gloves, drapes, and required instruments. This seems reasonable until one sees the prices. $1.60 for an intravenous needle, $50 for antibiotics, $20 for lab tests. Many Americans could not afford these prices. Well, back then. Many of these supplies are donated by industrialized nations to be distributed to the needy for free or minimal cost. The poor Haitians, ignorant and gullible, sink their meager life savings into health care without being cured. One problem I didn't anticipate was huge ulcers that refused to heal. They occurred everywhere, but most frequently were on the legs. One man had an ulcer that involved half of his lower leg extending from the knee to the ankle. Just looking at the ulcer turned even my hardened stomach. His black skin yielded to an ugly brick-red wound with ragged edges. It had rugged contours, mountains, and abysses of glistening raw meat, giving it a refractile appearance. Through the abysses filled with yellow pus coursed purple veins. In the middle of the wound, the underlying bone peeked through. It reminded me of a dissection from an anatomy class. The patient swatted at the flies constantly lighting upon the wound, using the crucifix of his rosary. Wounds such as this start from small cuts that refuse to heal. In the industrialized world, small cuts heal quickly because a well-nourished body has a functioning immune system to prevent infections and the capacity to manufacture extra tissues needed for wound healing. In those who are malnourished, the body cannot spare the extra energy since it is too busy maintaining basic metabolic processes. Consequently, these wounds continue to grow. The Haitians are unable to afford shoes and walk in raw sewage, so the wound gets infected and reinfected until it becomes unmanageable. Sickeningly often, only an amputation can prevent the infection from spreading. In spite of some frustrating diseases, working in the clinics was where I saved the most lives. The biggest killer in Haiti is diarrhea, and is the main reason why a large percentage of children die before age 5. In the industrialized world, diarrhea is usually caused by bacterial and viral infections, but in Haiti, worms and protozoa also precipitate this condition. These infections prevent the intestine from absorbing water so that it passes through rapidly, resulting in diarrhea. Diarrhea can be caused not only by infections, but also by malabsorption. The biggest culprit in Haiti is artificial milk preparations with lactose, a complex sugar that cannot be absorbed unless it is broken down by the enzyme lactase. Cow's milk contains lactose, so that Caucasians who have been weaned on cow's milk since the Middle Ages have been selected out so that almost all have lactase. Unfortunately, many blacks, as many as 30%, lack it and will develop diarrhea when given milk preparations that are distributed by altruistic organizations, sold in stores, and even advertised on television. The best milk for babies is breast milk. Cow's milk is for cows, people's milk is for people as babies. Over millions of years of evolution, in his opinion, breast milk has been refined to the perfect food containing all the essential vitamins, minerals, and immunoglobulins to protect against diarrhea. Nursing mothers have been encouraged to supplement their baby's diet with assorted concoctions, but it is not necessary. Breast milk has everything. Breastfeeding also serves as nature's method of birth control because nursing mothers ovulate less frequently. Since breastfeeding is not foolproof, American physicians never advocate it for simply that reason. Unfortunately, many Haitian women do not breastfeed, either because they have food to give the baby or because they themselves are too malnourished to produce milk. Another problem is that breastfeeding has been discouraged by American business interests. In the 1950s, it was fashionable for American mothers to bottle feed, providing a huge market for artificial milk. With increasing evidence that breast milk was better not only for the baby's health but also for mother-infant bonding, breastfeeding once again became the vogue. Since the milk producers had a shrinking market, they looked to other countries. Free artificial milk was distributed to naive women in third world countries for their babies. It lasted about 2 or 3 weeks, just long enough for the mother's own milk to dry up. They were forced to obtain the artificial milk again. Needless to say, it was no longer free. This practice was stopped after an acrimonious boycott of the Nestle Corporation, one of the milk producers. However, the damage was done. Up-and-coming women in third world countries prefer to bottle feed, and their babies get diarrhea more often. Diarrhea is lethal, not because of the infections that precipitate it, but from the dehydration. Without fluid, oxygen cannot be transported to the vital organs such as the heart. This results in the heart contracting less effectively so that the fluid is pumped even slower, a vicious cycle. The blood pressure drops, the child goes into shock and dies. To prevent this, the fluid must be replaced. Before doing this, I had to immediately identify the dehydrated babies. Jean was typical. His pathetic mother was attired in a filthy gray rag that could not hide her frail 70-pound frame. She held Jean up to me, not saying anything, as if her son's problem were obvious, and she was right. Jean eyed me suspiciously. As his mouth was slightly agape, I could see his parched tongue behind his dry lips. His dark brown eyes were sunk deep into his head, but alertly followed my every move. This was enough to diagnose dehydration. I undressed him, unwrapping the tight cloth that swaddled his torso. He responded by howling, tears rolling down his concave cheeks, thrashing his liberated stick-like arms and legs wildly as I invaded his personal space. This made me optimistic. First, because he could make tears, something severely dehydrated babies cannot do, and secondly, because he fought back. Babies who passively accept the poking and prodding of total strangers are quite sick. My hand instinctively felt the soft spot or fontanelle on the top of his head. It is the rhomboid indentation formed by the skull bones before they grow together during childhood. Through it, one can feel the cerebral spinal fluid which bathes the brain. When a child becomes dehydrated, the level of cerebral spinal fluid decreases and the soft spot sinks. Mothers of all cultures know this is a dangerous sign. In the United States, they take the baby to the hospital. In Haiti, they turn the baby upside down. I felt a depressed soft spot in Jean, even though he was crying. Then I gently pinched the skin over his chest. Instead of snapping back quickly, it slowly flattened like a tent whose main supports have been pulled out, another sign of dehydration. I listened to his lungs and heart in between howls, noting that they both sounded normal, but that the heart was beating rapidly, a compensatory mechanism for fluid loss. I asked the mother, "Les gens diarrhea, does he have diarrhea?" "Oui," she replied. "Elle la fièvre too." Yes, and fever too. "Ou bali tête ou? Do you breastfeed him?" "Non, mais pas Jean lait," she said, with her head dropping. "No, I don't have milk." Jean was moderately dehydrated and in the United States would immediately be admitted to a hospital. Unfortunately, on a typical clinic day, there were 20 babies like Jean. Since it was not practical to hospitalize them all, I taught the mothers to rehydrate them orally. A child with diarrhea cannot simply be given water because electrolytes, sodium, potassium, and chloride, are also lost and they must be replaced. The body has infinitely complex biochemical processes to maintain these electrolytes at constant concentration as they are vital for basic functions. For example, a slight change in the potassium concentration can result in abnormal heartbeats, muscle weakness, and in extreme cases, paralysis. I would give the mothers packets of electrolyte powder to be mixed with water. I had to explain how to make the solution and then have them repeat the directions until I was satisfied they understood. It was difficult until I learned Creole. When it was first discovered that babies could be rehydrated by this method, only electrolytes were put in the packets. Then it was noticed that by adding glucose, a simple sugar, the solution was absorbed with greater efficiency in the intestine. This discovery has saved more lives than all the cancer research combined. Oral rehydration is used extensively throughout the Third World in an effort to decrease the 5 million deaths caused annually by diarrhea and dehydration. At first, I had difficulty telling the mothers how much to add to a packet. I would say a liter, but they had no idea what I was talking about. Finally, I found a government pamphlet on oral rehydration that was written in Creole. Since few poor Haitians can read, it did them no good, but it certainly helped me. The Haitians drink a cheap local cola that is made of fruit juice and an ungodly amount of sugar that only a Haitian can tolerate. This pamphlet said that 3 of these cola bottles equals 1 liter. I would tell them to pour 3 cola bottles of water in a pot and boil it for sterilization, allow it to cool, and then add a packet of electrolyte powder and stir. Every time the baby had diarrhea, they were to give it a cup of the solution. Jean's mother understood the directions and repeated them perfectly. Not all the mothers did. One woman brought me her dehydrated 6-month-old, and after examining him, I took a packet of electrolyte powder and began explaining how to use it. First, place 3 cola bottles of water in a basin and boil it, I told her in my heavily accented Creole. Then add 1 packet of the powder. Give the baby 1 cup of the solution every 2 hours and add a half cup every time he has diarrhea. Give the water slowly with a spoon so the baby doesn't vomit. Satisfied, I asked her to repeat the directions for me. As she did so in slow, deliberate Creole, I beamed with self-pride. I was really saving a life. She then triumphantly concluded her rendition with, "Then put the baby in the basin for a bath." Many lives were saved, at least temporarily, by this method. Another life-threatening problem I frequently dealt with was abscesses. An abscess is a collection of white blood cells that accumulate to fight an infection. As it grows, it can break into the bloodstream and spread to the liver, brain, or kidneys. A widespread infection like this can be fatal. For this reason, an abscess must be drained and antibiotics given. The Haitians got them everywhere, on their heads, in their mouths, in the groin, and even in the rectum. They were painful and, if allowed to spread, fatal. After several months, I had drained every conceivable type. A young woman, Magdalene, came to me complaining of low back pain and fevers. Back pain is the bane of American medicine because there are few known causes for it and even fewer cures. 50% of American males present to their physician with back pain at least once in their life. Sometimes a cause such as a ruptured disc is found. More often, extensive testing reveals nothing, and vague diagnoses such as muscle strain are given, resulting in frustration for both the physician and patient. Haitians get back and neck pain from carrying heavy objects such as sacks of charcoal and buckets of water on their heads. This was not the case with Magdalene. She could barely walk and localized the pain to the left flank of her lower back. This area bulged when compared to the other side and felt hot. When I pressed on it, she screamed. If she had been white, I could easily have diagnosed the abscess because the skin would also be red, but in blacks I did not have this luxury. Nonetheless, I was certain she had an abscess. Ideally, this abscess could be drained painlessly and with sterile technique in an operating room. I did my best to simulate one in spite of the flies buzzing around. I had Magdalene lie prone on a wooden table and gathered the equipment I needed: gloves, iodine, anesthesia, gauze, alcohol, and a scalpel. I scrubbed her skin with iodine and saline until it was smooth, glistening ebony, and injected lidocaine, a local anesthetic, into the area I planned to cut. Quickly, I plunged the scalpel in her skin. She felt nothing. The blade made a half-inch incision, and as I pulled it out, a frothy, putrid white pus suddenly jetted into the air like a geyser. When the pressure was relieved, the pus stopped, but some still remained. After slightly lengthening the incision, I began to squeeze it out. "Ooh yee," she screamed in the high-pitched ululation unique to Haitian women. "Presque fin." "Almost done," I said. Anesthesia does not help when squeezing abscesses. The pus continued to exude with each squeeze until more than a cup had come out. Finally, after what seemed like an eternity to both of us, it stopped. Soaking some gauze in alcohol, I wrapped it into a cord and pushed it into the wound, letting the end hang out into the air. She yelled again. The alcohol stung. This would allow the pus to drain and prevent the wound from closing before the infection was eradicated. She thanked me repeatedly, even though she found the procedure so uncomfortable. Haitians are an appreciative and polite people. Magdalene also needed to be treated with penicillin, preferably intravenously every 4 hours. This is the best route to ensure that the antibiotic gets to the infected area. However, I had to compromise and give one dose intramuscularly and the rest orally. Penicillin is no longer the best drug for abscesses. 30 years ago it was, but some bacteria have developed resistance and require more expensive synthetic drugs unavailable in Haiti. Magdalene did very well. The fever stopped, the pain subsided, and soon she was walking comfortably. After a week, I pulled the gauze out of her back as the pus had stopped draining. She even got a job carrying food to the patients at Saint-Fie. Sometimes an abscess would not respond to penicillin. One child, Mary Math, had been abandoned at the clinics when I first saw her. Although her mother must have been heartbroken, for Mary Math it was a stroke of good luck. The missionaries of charity would find her a loving home in the industrialized world. Sometimes I wondered if I was doing a child a favor by saving it and returning it to the same miserable environment that spawned its initial state. But saving those who were to be adopted was very satisfying. Mary Math was having fevers and cried constantly. Covering her bald black head were little fluctuant mounds, all abscesses. They extended down the nape of her neck to her back. Otherwise, she appeared healthy. I took her to the children's home and proceeded to lance the abscesses. Pus spewed out of each one as the scalpel blade incised the skin of each mound. Poor Merrimath howled uncontrollably at what I hoped would prove to be justifiable torture. I wished I had the equipment to put her under general anesthesia. I started her on large doses of intravenous penicillin, but after 3 days, the high fever persisted and she refused to eat. Obviously, the penicillin was not working. I found a small amount of methicillin, but it was expired, meaning that its manufacturer no longer guaranteed its effectiveness. Methicillin is penicillin with a slight modification in its chemical structure that enables it to kill types of bacteria that have evolved penicillin resistance. I had no choice but to try it. The results were miraculous. Within 1 day, the pus quit draining and the fever stopped, never to return. Merrimath began to eat and gain weight. Soon she could sit, a huge smile displacing her chubby cheeks as she played with her toys. She is now being reared in Europe, making some couple very happy. Actually, expired drugs are usually effective. For legal reasons, drug companies underestimate when a drug will lose its potency. Unsellable expired surpluses are then given to third world countries. Both parties benefit because the drug companies get a tax write-off and pose as altruistic, while these poor countries receive medicine they could never afford. This practice often put me in a quandary. There is nothing more frustrating than putting a patient on a medicine and not seeing a response. If the drug is not expired, then I could assume it was the wrong drug and start another. But what if the drug is expired? Is the patient not responding because I chose the wrong drug or because it is no longer effective? I never knew. To help me choose the proper antibiotics, I set up a small laboratory. Armed with my microscope from medical school, an assortment of donated chemicals, slides, pipettes, and test tubes, I became proficient at simple tests like the Gram stain. Invented over 100 years ago, it is still the mainstay of modern medicine to determine the initial antibiotic treatment of an infection. Because of the biochemical structure of the cell wall, the Gram stain colors some bacteria blue, Gram-positive, while those that are Gram-negative appear red. Also, the bacteria have different shape, either rods or spheres, called cocci. This information, along with the identification of the infection, allows one to prescribe the proper antibiotic. For example, abscesses caused by Gram-positive cocci often respond to penicillin. On the other hand, infections caused by Gram-negative rods need gentamicin. Another skill I was forced to learn was dentistry. Poor Bernadette, a young woman with tuberculosis and malnutrition, also had an abscess the size of a golf ball under her chin. I lanced it, draining ugly yellow pus. The Gram stain showed Gram-positive cocci, so I began treating her with penicillin. However, 2 weeks later, the pus continued to pour out of the incision. Rather than start another antibiotic, I tried a novel approach, a more thorough examination of the patient. My Bible, the physical diagnosis book, said the abscesses under the chin might be caused by tooth infections, so I looked in her mouth. It was a complete disaster. 1/3 of her teeth were missing, and the remaining were decayed, eroded, and black. Some were so rotten they had split, each fragment being in a different direction. 2 were intact but loose, swimming in a pool of pus encased by necrotic gums, the source of the abscess. As I gazed at the mess, a putrid stench bludgeoned me. Haitians have pitiful dental hygiene. The entire country is addicted to sugar. Babies are weaned on sugar water and spend their childhood sucking on the cheap and abundant sugar cane, their main source of calories. A Haitian cannot even drink a glass of orange juice without 5 tablespoons of sugar. There's no strong movement to fluoridate the water. All these factors combine to make Haiti a dentist's nightmare. Anyone who has had an abscessed tooth knows the pain is excruciating, like a jackhammer pounding on the jaws, sending reverberations through the skull. Yet Bernadette, like many Haitians, learned to live with it, just as migraine patients become inured to their headaches. I was going to extract her teeth myself with a pair of pliers, but fortunately for Bernadette, a dentist from Connecticut was visiting. Dr. Jerry Lowney was a ruddy Irishman of 50 who continued his daily 5-mile run in Port-au-Prince in spite of 100-degree temperatures, devastating humidity, exhaust fumes from thousands of cars without mufflers, and steep hills. He deftly extracted Bernadette's abscessed teeth, earning her eternal gratitude. Within days, the pus stopped draining, and a week later, the abscess was gone. Jerry's impromptu dental clinic was the first thing I had seen in Haiti that ran efficiently. All his equipment was placed on a long table. To the right were 2 basins, one filled with alcohol and the other with water for the sterilization and cleaning of his instruments. To the left were thick-handled pliers with fearsome jaws of assorted sizes, shapes, and angles, each designed for specific teeth, whether upper or lower incisors or molars. These redoubtable implements are rarely seen in the offices of American dentists, since they are used to extract teeth rather than repair them. In the middle was Jerry's daughter, a teenager with a rare look of innocence, preparing syringes with long, thin needles for administering Novocaine. 2 chairs were in front of the table where one patient would have his teeth pulled while the other waited for the Novocaine to take effect. Jerry had good common sense and did not export the technology of his thriving orthodontic practice. No attempt was made to repair cavities or put on braces. The patient sat down, pointed to a tooth, and if Jerry felt extraction was warranted, out it came. He did not have a paucity of patience. To the Haitians, Jerry represented a way of ridding themselves of chronic, intractable pain. As I watched his forearm muscles bulge, I realized that brute strength along with finesse was needed. After watching Jerry pull out several teeth, I was ready. My first patient, a brave, unknowing young man, sat down and pointed to a rotting upper incisor. Slowly, I impaled the gum in front of the tooth with a long dental needle, giving a liberal dose of Novocaine. Next, I anesthetized behind the palate, doing this more quickly as it is painful. My patient did not even wince. Grabbing a mammoth pair of dental pliers, I grasped the tooth below the gum line and rocked it, feeling the laxity increase with each movement. Finally, I yanked down hard, and out it came. The root that had been submerged under the gum was the same size as the visible tooth. Proud of my new skill, I pulled out several more incisors, using only male patients since they did not shriek. Feeling confident, I decided to pull out a molar. Molars, the crunching teeth in the back of the mouth, are more difficult to extract because of their awkward location. Also, unlike the solitary root of incisors, molars have 3 roots anchoring them to the jawbone. I gave the patient twice the usual dose of Novocaine and grasped the tooth with the pliers that had its jaws oriented at a right angle to the handle. Rocking the tooth more to the outside than the inside, Jerry said that this decreased the chance of breaking the roots. I gradually loosened the molar. I gave it a quick tug, but it would not budge outward. After 1 minute of this wrestling, I could see my patient becoming uncomfortable, the clue being tears streaming down his otherwise stoic face. Putting his well-being in front of my ego, I asked Jerry for help. Within 1 second of his grasping the pliers, the tooth was out. He consoled me by saying all the work had already been done. Any child who had a tooth pulled received a free toothbrush with toothpaste. Predictably, the adults said they wanted one too. They even encouraged their children to have normal teeth pulled to obtain one. We had to stop distributing them entirely. Imagine having a normal tooth pulled just to get a toothbrush to sell for 1 gourd, 20 American cents. Since the demand was so great, I sometimes had to pull teeth without the help of a dentist. One young man came to me with a toothache. I examined him, found a rotten molar, and told him he needed it to be extracted. "But my wife is pregnant," he responded. I had only been in Haiti several months, and thinking I did not understand him, asked him to repeat himself. I had understood him correctly, but bewildered, I still made him repeat his statement slowly until it finally dawned on me that I was dealing with a superstition. I told him that taking out his tooth would not harm his unborn child. He politely acknowledged my viewpoint. However, he refused to allow me to extract his tooth. The Haitians had many superstitions, but most were more pragmatic than this gentleman. Perhaps the pain was not yet severe enough. Every time I worked in the clinics, I would see a patient that belonged in a medical textbook. In medical school, this is called a classic presentation. It is the way a sick patient is supposed to look. For example, a man having a heart attack should be an overweight, overworked 60-year-old, his clenched fist on his chest and sweat dripping from his brow, who says that after eating a large meal he walked briskly up a flight of stairs in cold weather and suddenly experienced a dull ache that in the left side of his chest that rapidly crescendoed to a crushing pain that spread to his shoulder and left arm. In the real world, heart attack patients do not read the textbooks. Some complain of mild indigestion, others just have jaw pain. Some do not have any symptoms at all. They simply arrive for their checkup one day and their doctor sees the heart attack on a routine electrocardiogram, a test that analyzes the forces of the heart muscle. In actuality, classic presentations are the exception, not the norm. However, they are more frequent in populations that either ignore or do not have access to medical care. One woman gave a complaint to a visiting doctor. He did not know Creole, but when he examined her, he noted a rapidly pounding pulse and asked me to look at her. As I watched her walk over to me, I could see tuberculosis written all over her. Gaunt and weak, she needed help sitting on the wooden chair beside me. When she took her shirt off, I could see her heart beating through her thin chest. Her pulse was 130. The normal pulse in healthy adults is near 70, but in my clientele, the anemic and malnourished Haitians, it was closer to 100. I listened to her heart. The sounds were loud, but she had no murmur. I also listened to her lungs, expecting to hear the wheezes of tuberculosis, but they were completely clear. Like a typical American physician, I immediately considered cancer as a possibility, but further examination revealed the classic signs of another problem. When I tapped her kneecap with my reflex hammer, her calf flew up into the air, amusing the other patients who kept asking me to do it again. Her blood pressure was 150/60, high for a young woman. There were random contractions of small muscle groups on her legs, fasciculations which looked like areas of bobbing gelatin. The key sign was in front of her neck, where a mass bulged beside her windpipe. When I put my stethoscope on it, I could hear blood rushing through it. It was her overactive thyroid gland. I had seen cases of hyperthyroidism before. It is fairly common, but never to this extreme. Usually, only 1 or 2 signs are present when the disease is diagnosed. It is rare to see an American patient with a bulging thyroid, rapid pulse, brisk reflexes, high blood pressure, and fasciculations all at the same time. Every physician knows hyperthyroidism is common, so the threshold for screening for it is low. Most hospitals even do thyroid testing as part of their routine blood work, so it is detected before the patient is symptomatic. The definitive treatment is to either surgically remove the thyroid or destroy it with radioactive iodine. With my facilities, these were not viable options, so I treated her medically with a drug called Enderol. It did not eliminate her hyperthyroidism, but at least some of her symptoms abated, so she was comfortable. Haiti is ideal for the connoisseur of venereal disease. My typical clinic was replete with eroded penises, abscessed vaginas, and huge groin lymph nodes from syphilis, gonorrhea, and chlamydia. Even in the industrialized world, patients will ignore horrible genital lesions because they are embarrassed or delude themselves into thinking they will disappear. Syphilis especially ravaged the Haitians because, when untreated, it could spread anywhere in the body. Only recently controlled in the United States, syphilis infected 5% of the American population at the turn of the century. It decreased because gonorrhea, which became an epidemic in the 1960s, has a shorter incubation period but is treated with the same drug, penicillin. Consequently, subclinical syphilis is eradicated when gonorrhea is treated. Although syphilis is considered to be a disease of the poor, it is not uncommon for a respected, God-fearing member of the community to be hospitalized for a symptom that proves to be reactivated syphilis. For the sake of the patient's reputation and domestic tranquility, the diplomatic physician treats the disease without telling the family or documenting it. Syphilis has a fascinating history. Its existence in pre-Columbian North America has been proven by the syphilitic bones found in Indian grave sites. Columbus's sailors probably carried it to Europe, where it rapidly spread across the continent. Called the Great Pox because of its characteristic rash, it made its way into Elizabethan literature. In France, having a syphilitic rash was fashionable amongst the sexually avant-garde aristocracy. Many Haitians come to the clinic with the first stage of syphilis, a painless ulcer or chancre on the genitalia. The chancre regresses. The chancre regresses whether treated or not. The difference is that with the penicillin, the syphilis is eradicated, whereas without it, the infection silently percolates, eventually causing rash, fever, and swollen lymph nodes, the second stage. When treated at this stage, syphilis can still be cured without complications. The real horror of syphilis is when it progresses to the tertiary stage, where its effects are devastating. It can attack the skin and eat through, destroying everything in its path. One of my patients had a huge abyss between her left eye and upper jaw that extended to the middle of her face, eradicating her nose. I could peer into this crater and see her teeth growing through her upper jaw in front of her palate. The heart, brain, and spinal cord were also fair game. Tertiary syphilis attacks the aorta, rendering its valve incompetent and causing intractable heart failure. It destroys the part of the spinal cord that allows one to perceive pain. These patients would get ulcers on the bottom of their feet and never know it. When infected, the disease would painlessly spread to the ankle joint, resulting in a crippled and unemployable patient sentenced to a life of begging. Other patients had deteriorating mental functions, becoming forgetful, irrational, and belligerent. Many Haitians have no concept of mental illness and would abuse or ostracize those afflicted, thinking they were possessed by the devil. I quickly learned that any complaint from a fever to an inflamed eye to a foot ulcer could be masquerading as syphilis and warranted an examination of the genitalia along with at least a query about previous lesions. Other venereal diseases also progress to horrendous states. One type spread from the genitalia to groin lymph nodes that then ruptured through the skin. Unlike syphilis, these pus-draining abscesses required a month of oral antibiotics, tetracycline 4 times a day. Only the most compulsive patients will obediently take a pill 4 times a day, and few Haitians fell into this category. Furthermore, tetracycline is considered to be a panacea and is hawked by street vendors to cure anything from diarrhea to ingrown toenails. My patients would sell it, especially when they were hungry. When it comes to food versus medicine, food always wins. When I noticed my patients were not improving, I gently urged them with my tactful American bedside manner to take the medicine. This approach failed miserably. I soon realized that subtle suggestions were a waste of time. With no attempt at diplomacy, I told my patients to take the medicine or forget about sex. This they feared more than any voodoo god. My cure rate increased dramatically. After seeing thousands of sick Haitians, I learned how to treat their problems. Nonetheless, I was occasionally reminded of American medicine. One elderly man came to the clinic complaining of difficulty in breathing. He managed a weak smile with his blue lips, even though he was inspiring deeply at a high rate. His legs were swollen, and he had a scrotum the size of a grapefruit. When I osculated his barrel-shaped chest, I could barely hear the air struggling to move through his damaged lungs. He had emphysema. It was so bad that his heart was weakened from constantly trying to push fluid through the non-compliant lungs. Consequently, the fluid trying to enter the heart backed up, causing the swelling. A common problem in the United States, emphysema, is rare in Haiti because the poor cannot afford its most common cause, cigarettes. This man managed, though, and not realizing the connection to his present state, proudly told me he had smoked a pack a day since he was 8. Emphysema, accompanied by heart failure, carries a poor prognosis anywhere. In a sense, he was lucky. In the United States, he would have spent his last year in a living hell, frequenting hospitals to have a tube rammed down his throat so that he could be placed on a respirator. Here, I just put him in sans-fee and allowed him to die quickly and peacefully. Unfortunately, there will soon be more patients like this in the third world. Cigarette companies, with their shrinking markets in the industrial world, are pushing their product aggressively on developing nations. Smoking cigarettes in Haiti is synonymous with increasing status. Every up-and-coming Haitian male smokes. Working in the clinics is where I learned the most. The Haitians taught me about tropical medicine and about themselves. It was wonderful to be a physician and only worry about your patients. I was free from the drudgery of endless paperwork and meaningless ritual. I was not forced by legal considerations to inconvenience my patients with silly tests to confirm the obvious or rule out the ridiculous. My patients trusted me and thanked me, even when I could do little to help. There was a dark side, though. The volume was so overwhelming that I could not help everyone. The mothers stood there with their pleading eyes asking me to save their dying children. It simply could not be done. I had to choose who would live and who would die. I sometimes got depressed, but I made the decisions. Someone had to. But I never got used to it, and I knew that no matter how long I stayed in Haiti, I never would.